So category 1, the normal category, and there's no features to suggest infection. It's normal. And to make sure you mention that this doesn't exclude an early case of COVID infection. So if you still think about it clinically, you should still correlate it with a PCR test. I won't show an example of a normal case. I'm assuming we can all familiar with that already. But category 2, so the indeterminate category. So we're starting to see ground glass opacities, but without the classical peripheral, basal, rounded morphology. And you may see consolidation, which is not, it's not what we expect. It's not rounded, but it's not a single lobe. Maybe it's perihilar. And I'll show you some examples here. But the concluding statement we've suggested is its findings that may be present in many processes, including COVID-19. And so this could be infectious as well as non-infectious processes. And if you're worried, really you should be doing a PCR test. So this is a case now we've had here in Australia of an 85-year-old female patient who has presented with cough and dyspnea. And on the referral, we have the information of suspected COVID. We have ground glass opacity here, which are bilateral and they are perihilar, but there's no consolidation and no crazy paving. And when we look at the coronal reformats, you can see very clearly that the ground glass opacity is perihilar and centrilobular. So this appearance and this distribution of the ground glass is indeterminate, and we would recommend swabbing up to twice in the first 4 days, with a repeat swab at 4 days if the first swab is negative. Here we have a different patient, 40-year-old lady this time, who is presenting with chest pain, and her study shows bilateral large foci of ground glass. There's some consolidation there in the middle lobe. It's not rounded in morphology. There are some parts which are peripheral and some which aren't. And when we look at the sagittal and coronal reformats, we can see that the changes are really layering against the fissures. And so this distribution probably more likely to be aspiration, or it could be infection, or it could be pulmonary hemorrhage. The clinicians in this case weren't really sure what was going on, and they actually protocoled it as a CT pulmonary angiogram study, which was also negative for PE. So really not sure what was happening with here, and we recommended that they proceed with the COVID swab in this patient as well. Let's move on now to category 3, which is the typical findings. And this imaging findings really requires at least one of these typical findings to be present as the predominant pattern, recognizing that there may be overlap with other processes. And so in our concluding statement, we've said that there are typical features of COVID-19, but these may be seen in other processes like influenza or with organizing pneumonia. The organizing pneumonia reaction is obviously present in response to many different triggers. And so it really depends on whether the patient has had a positive PCR test result when you're looking at someone with organizing pneumonia. So here we have some typical findings. We have an 80-year-old male patient who is swab positive for COVID-19, and there are multifocal bilateral ground glass opacity, basally predominant, and multiple peripheral areas, and then some slightly more central ground glass areas as well. These opacities are ground glass, where we can see the lung vessels clearly through the opacity. There's no consolidation, and there are some areas of crazy paving that we see here with the blue arrows. Here in these crazy paving areas, we see intralobular interstitial tissue, as well as interlobular septal thickening. And here we have another patient, a 60-year-old lady this time, who is confirmed to have COVID on the PCR testing. And she has presented with abdominal pain. And her oxygen sats are 97% on room air, which is not too bad. But her CT shows multiple small peripheral areas of ground glass opacity in the bases. There's no crazy paving. And the coronal reformats, again, demonstrate the peripheral nature and that there's a slight basal predominance. So this is also a typical case, but the findings are more mild. Let's move on to this case now, an 80-year-old female patient who has presented with wheeze, and she has basal crepitations on examination. She also had a positive swab, and she moved on to do CT, and this showed multiple peripheral ground glass opacities. Each opacity is quite small, but overall the extent in the bases at least is quite high. So this is still a fairly mild case, but given that this is a positive case confirmed on PCR, you'd want to be really taking a close clinical management, and this may be a patient who has a follow-up study during her admission to hospital. And when we talk about the fourth category, we're looking at an alternative diagnosis because the findings are really very atypical for COVID-19. So this requires an absence of the typical or indeterminate findings and something else present suggesting a different diagnosis. So this is a case here of a 52-year-old man who's had a 3-day history of fever, non-productive cough, and sharp non-pleuritic chest pain. And his CT shows some focal consolidation, posterior segment, left upper lobe. It's very focal. There's no ground glass opacity. The lungs are otherwise clear. This is very atypical for COVID-19. It's much more likely to represent bacterial pneumonia, so a different cause of infection. And we have here an 87-year-old lady presenting with fevers and shortness of breath, who'd had a swab, but the result was unknown at the time of the CT. And the CT here shows ground glass opacity in the posterior segments of both upper lobes, as well as in the posterior right lower lobe. However, she has a number of other findings as well. So she has bilateral pleural effusions, and we found out subsequently that her right pleural effusion had been drained of fluid for over 1 litre before her trip to the CT scanner. She has cardiomegaly, and she's had previous bypass grafting. And when we look at the coronal reconstruction, we can see that the ground glass opacity is more perihilar than peripheral. So the most likely diagnosis in this patient is congestive cardiac failure, although the size of the effusions has been quite large, and the patient's age suggests that malignant effusion may also be happening here. So we'll briefly talk about when CT should be considered, and then I thought we might have a brief pause if anybody else has any questions before we move on to the last little bit. So in summary, when we should consider doing a CT is if we think there's a complication to the patient's pneumonia. So do you think they might have an abscess? Have they got a pneumothorax? You know, is there more of a complicated picture here? And this is very much the case as well in patients who are in ICU. Is the clinical picture deteriorating? Do we understand why? If we don't know why, perhaps we need to look for other things. To help triage sick people in an epicenter setting, and again, I stress that this is if you have a really high pretest probability and people are unwell, then you're not so much triaging for infection, you're really triaging to find the patients who are really unwell. And then, of course, for the usual clinical indications that we would consider CT. So if you think someone's had a pulmonary embolus, if you're worried about aortic dissection, if the chest x-ray is really worrisome, you think that there's a large mass or a cavitating lesion, these are all reasons to proceed to CT in people who are unwell. Let's move on now and talk about the role of the chest x-ray. So X-ray has a lower sensitivity for the diagnosis of pneumonia generally compared to either a PCR test or the CT scan. And we don't have as much literature on the use of chest X-ray compared to what we have for CT. The findings in the chest X-ray typically take a little bit longer to become to peak. So rather than peaking at day 6 to 10 for CT, they peak at about day 10 after the onset of symptoms. But the chest X-ray findings, it may be a blunter tool, but they do mirror those that we find on CT. So bilateral peripheral opacity, usually with a basal predominance. And the atypical findings are the same. They may be harder to see on the X-ray. So we may not see the adenopathy, or we may not see the small cavitating nodules, but pleural effusion is still atypical. Pneumothorax is still atypical. And the perihilar distribution of consolidational pulmonary edema is still atypical. So we've taken an approach here at ANSTA with chest X-ray guidelines, a 4-category approach. And really, when we look at chest X-rays, it's so important to see what was present before, particularly if we've had portable radiographs, at multiple times during the patient's admission. Important to note any atypical findings down for future reference. And more so than on CT, pre-existing lung disease is not your friend when you're interpreting chest X-rays in unwell patients in hospital. So the normal category, it looks normal. You can't say that the patient isn't infected, particularly in the early stages of disease. The indeterminate category. So we've tried to mirror the language between the chest X-ray and the CT classifications, make them as similar as possible. But when we talk about chest X-rays, what you're really saying is, can you see consolidation or ground glass? You cannot usually tell if there's consolidation alone or ground glass alone. Sometimes you can, often you can't, particularly on the portable X-ray. If it's present, it's not predominantly basal, peripheral, and bilateral. If you have multifocal consolidation, it's not rounded, it's not focally lobar, it could be perihilar. And so the concluding statement is exactly the same as the indeterminate category for CT. These findings may be present in many different things, including COVID. The typical category, again, harder to pick up some of these subtle findings on the X-ray, but in principle, they're the same as the typical findings on CT. Lower zone, peripheral, multiple opacities, bilateral. And then the concluding statement is typical features of infection from COVID, but you may still see it in other things like flu. Category 4, looking at other diagnoses. So you don't see the typical or indeterminate findings, but you do see something else. So you may see something that looks like congestive heart failure, pulmonary edema, pneumothorax, and you would say here they're not likely to be COVID, and we think about what else it could be. So let's do a few examples here. Here we have typical appearance on a chest X-ray where we have bibasal peripheral ground glass opacity. And this X-ray was actually from our previously seen 80-year-old patient who was wheezing and had typical findings on CT. You can see, just looking at this, it is so much more challenging to interpret this in a patient who's not well. It's an AP film, it's not PA. They have a large heart, there's a pacemaker. There's so many more technically challenging factors to interpret on a chest X-ray than on a CT. Here's another example. This was performed on a 67-year-old female patient who has a background history of bronchiectasis, and her shortness of breath has been worsening. She does have a small pleural effusion, which is atypical, but she has multiple peripheral foci of consolidation. She has left lower lobe bronchiectasis. There's another focus of consolidation here in the left base. So this is an indeterminate study. Really very hard to look at this chest X-ray where there's pre-existing disease and be certain of a diagnosis. So the CT for this patient, we can see with the swab result now pending that there is diffuse and bilateral ground glass opacity. It does not have a typical peripheral distribution or rounded morphology. and that there is left lower lobe bronchiectasis, which is likely to be chronic with superimposed consolidation. However, go back and look at the previous, because 2 months previously she'd had another CT and all that ground glass opacity was there before. The only difference is that the amount of consolidation in her left base has increased in the interval, and that's causing her symptoms. So really very difficult to interpret that chest X-ray, and the CT and the prior imaging has answered the question for you there.